Okay, migraine symptoms. Typically unilateral, although it may occur behind both eyes or across the entire front of the head. A throbbing or boring head pain, accompanied at times by nausea, vomiting, mood change, fatigue, or photophobia. An aura with visual disturbance, including flashing, zigzagging light, blurred vision, or visual field defect lasting 15 to 50 minutes, may precede the migraine. May experience temporal or permanent neurological defects such as paralysis, numbness, tingling, or others. A family history is common. Motion sickness or cyclic vomiting as a child is also common. Migraine in children may be seen as recurrent abnormal pain and malaise. Of these patients, 60 to 70% are girls. Migraine's prevalence is highest between age 30 and 39 and progressively decline after age 40. Migraine attacks may be shorter and less typical with advancing age. New onset migraines are uncommon after the age of 50, and these patients should be worked up for secondary causes such as vascular lesion, intracranial hemorrhage, infarct, masses, or giant cell arteritis. Note, most unilateral migraine headaches at some point change size of the head. Headaches always on the same side of the head may have another cause of headache, for example, intracranial structure lesion. Determine if headaches precedes visual symptoms, which is more common with arteriovenous malformation, mass lesions with cerebral edema, or seizure foci. Sign, usually none. Complicated migraines may have a permanent neurological or ocular deficit. International classifications. Consult international classifications for headaches disorder. 1. Migraine without aura, common migraine, 80%, lasting 4 to 72 hours. Unilateral location, pulsating quality, moderate to severe pain and or aggravations by physical activities. Nausea, vomiting, photophobia, and phonophobia. Migraine with typical aura, classic migraine, 10%, fully reversible binocular visual symptoms that may perceive as monocular, for example, flickering lights, spots, line, loss of vision, or fully reversible unilateral sensory symptoms. Symptoms gradually develop over 5 minutes and lasting between 5 and 60 minutes. No motor symptoms are present. 3. Typical aura without headache, a cephalic migraine. Visual or sensory symptoms as above without accompanying or subsequent headaches. Retinal migraine, fully reversible monocular visual symptom, for example, scintillation, scotoma, blindness, accompanied by headaches, fulfilling migraine definitions. Appropriate investigations to exclude other causes of transient monocular blindness should be completed. Associations or precipitating factors. Birth control or other hormonal pills, puberty, pregnancy, menopause, foods containing thiamine or phenylalanine, nitrate, alcohol, emotional stress, or bright lights. Workup. 1. History may establish the diagnosis. 2. Ocular and neurological examinations, including refraction. CT scan or MRI of the head is indicated for atypical migraine. Consider checking for uncontrolled blood pressure or low blood sugar. Treatment. Avoid agents that precipitate the headaches. For example, stop using birth control pills. Avoid alcohol or any food that may precipitate attacks. Reduce stress. Refer to neurologists or internists for pharmacological management. Prophylactic therapy. Use in patients with frequent or severe headache attacks, for example, 2 or more headaches per month. For those with neurological changes, including beta blocker, calcium channel blocker, antidepressants, and other. Follow up, evaluate in 4 to 6 weeks to assess the efficacy of the therapy.